Every prescription medication your doctor gives you comes with a document. It is usually folded into a small white packet that falls out when you open the box. Sometimes it is printed on the back of the pharmacy bag. Most people glance at it and set it aside. And somewhere in that document, past the instructions, past the dosage information, past the drug interactions, there is a section called adverse reactions, side effects. And right there, in plain print, is the thing nobody warned you about. If you take a blood pressure medication called amlodipine, sold under the brand name Norvasc, and one of the most prescribed medications in the country for adults over 60, the FDA label lists its most common adverse reaction right at the top of that section. Not nausea, not dizziness, not fatigue. Edema, swelling of the lower legs and ankles. It is sitting right there in the prescribing information your doctor received before writing that prescription. And there is an excellent chance that nobody mentioned it to you. I am Dr. Mary, and today I am going to show you exactly why that swelling happens, why the standard response to it may actually cause more harm than the swelling itself, and what the real conversation with your doctor should look like. If you are over 60 and you are on amlodipine, there is a good chance you already know what I am about to describe. At some point after you started that medication, your ankles began to swell by the end of the day. Your shoes started leaving marks on your skin by evening. You looked down and noticed the skin around your ankles looked puffy tighter than it used to, maybe even a little shiny. You told your doctor. And one of two things happened. Either you were told it is nothing to worry about, just part of getting older, drink more water, or your doctor added another medication to address the swelling, a water pill, a diuretic, to help your body flush the fluid. Both of those responses miss what is actually happening inside your legs. And in a moment, I am going to explain why the second one, adding a diuretic on top of amlodipine, is one of the most common and most consequential prescribing errors in senior care today. Stay with me for the next 2 minutes, because what I am about to show you about the mechanism changes everything about what the solution actually looks like. I want to tell you about a woman I will call Dorothy. Dorothy was 72. She had been on amlodipine for 3 years to manage her blood pressure, and it was doing its job well. Her numbers were good. Her cardiologist was pleased, but about 6 weeks after she started the medication, Dorothy noticed her ankles. By 4 p.m, they were visibly swollen. By evening, her shoes left marks on her skin. She had to buy wider shoes. She stopped wearing certain clothes because her legs drew attention. She told her doctor. He told her it was not dangerous, but prescribed furosemide Lasix, a loop diuretic, to help with the fluid. The swelling improved, a little, but Dorothy started to feel something new. Tiredness that went bone deep, leg cramps that woke her up at night, a thirst she could not fully satisfy. She went back to her doctor. He checked her electrolytes. Her potassium was low. Her magnesium was low. She was given potassium supplements. More pills. By the time Dorothy found this channel, she was taking 5 medications when she had started with 1. She had become caught in something that has a name in pharmacology, a prescribing cascade, a chain reaction where one medication's side effect leads to a second medication, and that second medication creates its own damage, which leads to a third. And it all started with a side effect that was printed, in plain language, on page 4 of her original prescription insert. The one nobody read to her. I am going to tell you what happened to Dorothy. But first, I need to show you the exact biology of what amlodipine does inside your legs, because understanding it is the only way to understand why that water pill could not possibly have fixed it. Here is what amlodipine actually does to your legs, and why it has nothing to do with fluid retention. Amlodipine is a calcium channel blocker. It lowers blood pressure by relaxing the walls of your blood vessels, specifically the arterioles, the small vessels that feed your capillaries. It does this very effectively, and for most people with hypertension. That protective effect is real and important. But your body has a balancing system. When your arterioles dilate and more blood flows into your capillary beds, the venous side of your circulation, the vessels that carry blood back up toward your heart, normally constricts slightly to equalize the pressure. This automatic response is called postural vasoconstriction. Its job is to prevent fluid from being forced out of your capillaries into the surrounding tissue, especially when you are upright and gravity is pulling blood downward. Amlodipine blunts that balancing response. When you are standing or sitting, gravity pulls blood down into your legs. Your arterioles are dilated, feeding more blood into your capillaries than usual. But the venous compensation that should equalize that pressure does not happen fully. So capillary pressure rises. And when it rises past a certain threshold, fluid is pushed out of the capillary wall and into the space between your cells, the interstitial space. That is the swelling you see in your ankles. Not extra salt, not kidney failure, not heart failure. Fluid being displaced from your capillaries into your leg tissue by a pressure imbalance that the medication itself creates. This is why amlodipine swelling behaves the way it does. Worst in the afternoon and evening, when gravity has had the longest time to work. Better overnight, when you are lying flat and gravity no longer pulls blood down. And this is also why, and I need you to hear this, a diuretic cannot fix it. Diuretics tell your kidneys to excrete more fluid from your bloodstream. But the fluid causing your ankle swelling on amlodipine is not sitting in your bloodstream waiting to be filtered. It has already left your blood vessels. It is in the tissue itself. A diuretic cannot reach it there. What the diuretic does reach is your blood. And specifically, the electrolytes, the magnesium, the potassium, the minerals your muscles and nerves depend on. When those drop, your legs pay a completely different and much heavier price. Which brings me back to Dorothy. Because this is exactly what happened to her. And there's a piece of research that proves it was not just her experience, it is happening at scale. Stay with me here, because what the research found about how often this cascade happens and what it does to people is the thing that should have been in every doctor's office conversation about this medication. A 2020 published in JAMA Internal Medicine reviewed data from nearly 4,100 older adults and found that patients who started a calcium channel blocker like amlodipine were significantly more likely to be prescribed a loop diuretic within just 90 days, confirming that the progression from blood pressure medication to water pill is not a rare outlier. It is a documented, measurable, system-wide pattern. And a 2025 study published in Frontiers in Pharmacology examined what that cascade does to patients once it is in motion. Researchers found that the combination of amlodipine and furosemide not only fails to resolve the edema effectively, but exposes older patients to a significantly elevated risk of electrolyte imbalances, dehydration, and falls. Think about what that means. A side effect listed on the prescribing document, a second medication added to treat that side effect, and a measurably worse outcome, more pills, depleted electrolytes, leg cramps, fall risk, than if the original conversation had simply gone differently. Dorothy's story is not unusual. According to the research, it is extremely common. And that is exactly what makes it important. Not because amlodipine is a bad medication, it protects a lot of hearts, but because the side effect that is printed on its label has a right answer and a wrong answer. And far too many people are getting the wrong one. Let me show you what the right answer looks like. I want to be direct with you here, and I want you to hear this as something you have every right to act on. You are not questioning your doctor's judgment when you bring this information into the appointment. You are giving your doctor something they need, context, symptoms, and the language to connect them. That is a gift, not a challenge. So here is what the evidence supports, and here is what you can ask for. The first thing to understand is that amlodipine swelling is dose-dependent. The FDA label confirms this with specific numbers. At 2.5 milligrams, edema affects approximately 1.8% of patients. At 5 milligrams, that rises to about 3%. At 10 milligrams, the highest common dose, it reaches approximately 10.8%. And for women specifically, the FDA data shows edema rates as high as 14.6% at the 10 milligram dose, compared to 5.6% in men. What that tells you practically, if you are on the 10 milligram dose and experiencing significant swelling, a conversation about dose reduction is legitimate and evidence-supported. Your blood pressure may still be well managed at a lower dose, and the swelling may reduce or disappear without adding any additional medication. The second option is a medication class switch. If amlodipine is causing persistent edema at any dose, your doctor may consider switching you to a different type of blood pressure medication, an ACE inhibitor, an ARB, or a different class of calcium channel blocker that does not carry the same peripheral edema risk. The third option, if amlodipine is still the right choice for your blood pressure, is combination therapy. Research published in the American Journal of Medicine found that adding an ACE inhibitor or ARB to amlodipine significantly reduces the peripheral edema it causes because those medications promote venous dilation that compensates for the arterial dilation that creates the swelling in the first place. All three of those options address the root cause. None of them add a medication that depletes your electrolytes and leaves your legs cramping at night. If you are already on a diuretic that was prescribed specifically for the amlodipine swelling, ask your doctor whether it is still necessary. Ask what your current potassium and magnesium levels are. If you have not had those tested recently, ask for them by name. Furosemide is efficient at depleting both, and many people in this situation are running low without knowing it, which is exactly why the cramps start. If you have ankle swelling and leg cramps and fatigue all occurring together, name all three in the same sentence at your next appointment. That combination, in someone on amlodipine and a diuretic, is a recognizable clinical pattern. Naming it clearly gives your doctor the information to respond to it correctly. Tomorrow morning, before you take your medications, open your phone and type 3 words into a note. Amlodipine, swelling, cascade. Set a reminder to show that note at your next appointment. Those 3 words may prompt a conversation that changes your medication picture more than anything else you do this year. Now, Dorothy. When Dorothy finally had this conversation with her doctor, armed with the right language, he reduced her amlodipine dose and replaced the furosemide with a different combination approach. Within 3 weeks, the deep fatigue lifted. Within a month, the nighttime leg cramps stopped. She did not need 5 medications. She needed the right one, at the right dose, with the right partner, and a conversation that should have happened at the very beginning. 3 things to carry with you. 1. Amlodipine swelling is caused by a capillary pressure imbalance, not fluid retention. That is not a technical detail. It is the reason diuretics cannot fix it at the source. They treat the wrong mechanism, and in doing so, they deplete what your legs actually need. 2. The prescribing cascade from amlodipine to furosemide is one of the most documented medication chain reactions in senior care. It is confirmed in a 41,000 patient study in JAMA Internal Medicine. It is not rare. And the outcome, electrolyte depletion, leg cramps, fatigue. Fall risk is measurably worse than addressing the swelling at its source. 3. There are real, evidence-supported alternatives: dose reduction, medication switching, or ACE inhibitor combination therapy. The conversation is yours to initiate, and now you have everything you need to initiate it well. Before I go, I want to leave something with you for next week. Today we traced one prescribing cascade: amlodipine causing swelling, furosemide being added, electrolytes being stripped, legs paying the price. One medication, one response, one-chain reaction. But there is a second cascade, and it is quieter than this one, more insidious, because it does not show up in your ankles where you can see it. It shows up in your nerves, in the burning at the bottom of your feet, in the tingling in your toes that gets worse at night, in the electric cramps that feel completely different from ordinary muscle cramps, and that most people, and most doctors, assume are caused by diabetes or aging. They may not be. The medication that starts this second cascade is one that millions of seniors over 60 take every single day. And the nerve damage it may be quietly contributing to has a specific, documented, and in many cases, fully reversible cause. In next week's video, I am going to name it, trace it, and tell you what the research says about stopping and reversing it. Subscribe so you do not miss it. If today changed how you see the paper that falls out of your prescription box next week is going to do the same thing for the medication most likely sitting beside it. I will see you then. Take care of those legs.